Okay, hello everyone and welcome to December's Completed Life Initiative Lunch Hour. Today we are joined by Dr. Timothy Quill, who is a renowned professor of palliative medicine at University of Rochester Medical Center, and he is an esteemed member of the Completed Life faculty. And so today we're delighted to welcome you all for this lunch hour. It'll be an hour and a half, and the session is recorded live, and the recording will be available on our website in the next few days. So stay tuned for that in case you want to go back and watch the recording. In case you haven't met me, I am Sarah Kiskadden-Bechtel. I'll be your host today, helping to moderate the question and answer. And I'm the program director of the Completed Life Initiative. So it's a delight to meet you all today. And hello and welcome. And I will start sharing my slides and turn it over to Dr. Quill. So Tim, please take it away.
Okay. All right. Well, thank you, Sarah, for setting all of this up and for making it work and for pushing our thinking in these domains further than perhaps it has been pushed in the past. So it's great to be with you all. And the gist for what I'm going to do today, what I'm planning to do is I'm going to talk about the possibility of stopping eating and drinking toward the end of life. And this may not be everybody's first choice in this zone, but it is something probably people should be more aware of. And hopefully you'll understand that more as we move through all of this. I think the plan is for me to go through my talk, which will include a couple of cases at the end. And then at the end, we'll have a conversation about all this. So please write down your questions and areas that you want us to discuss more, and we'll come back to those at the end. Now, am I advancing these, or are you, Sarah? You are.
I got it under control, Tim.
Got it under control.
No worries. Go ahead.
All right. So I don't have any financial conflicts of interest, at least in this zone. I am editing a book on voluntarily stopping eating and drinking, so a shameless plug for a book that's coming out next year. And I also have, I'm an advocate for expansion of palliative care and hospice and for allowing both stopping eating and drinking, as well as other last resort options such as physician-assisted death and voluntary active euthanasia. So I do advocate for those things as well. So I have a perspective on this topic. So we're going to start out by talking about the clinical issues around voluntarily stopping eating and drinking. So many patients, as they get sick, have some questions that occur that they may or may not voice. And I would suggest that a lot more people have these questions than actually voice them. And the two general big categories in this zone are: what options do I have if my dying becomes unacceptably difficult in the future? And that's a question that a lot of people have who are getting sick. Actually, a lot of people who aren't sick have it, as people who are getting older, perhaps they have illnesses in their family. They wonder about what might that look like for me, and what options do I have? And then a much smaller group would ask the question, what options do I have right now? So again, this is a much smaller group of people who might be having suffering that is really unacceptable to them at this moment. So again, we're going to talk about both of those groups and think about some of the options that might be available to them. And this slide has pretty much the full range of what I call last resort options. And last resort meaning these are options that can be a way to respond to unacceptable suffering, and also a way to respond when a person might say, I'm ready to die now. So just to quickly run through these to just set the landscape of these options. And this is in sort of order of societal acceptance of permissibility. So again, the first option might be accelerating opioids for sedation, to sedation for pain. So people who are worried about having unacceptable pain or shortness of breath can know that there's wide acceptance of giving whatever dose is needed of opioids, things like morphine, to relieve that suffering. So if a little works, that's great. If it takes a lot, if it takes a huge amount, that's also permissible as long as your goal is to relieve the pain or the shortness of breath. Second category is life-sustaining therapy. So people have to give their permission to be on life-sustaining therapy, and they can take that permission away at any time, even if their desire is to die. And some of the life-sustaining therapies are, big ones like ventilators or breathing tubes or other kinds of intravenous therapies that are running continuously. Some of them are little life-sustaining therapies like steroids for brain cancer or those kinds of things. So all these treatments can be tried when you're not sure if they're going to help, and they can be stopped even if your desire is to die sooner rather than later. Third option is voluntarily stopping eating and drinking, which I'm not going to talk about at this moment, but that's what we're talking about today. But the fourth option would be palliative sedation, potentially to unconsciousness. So if people are in extreme levels of distress and pain, they can be given sedatives, again, usually in proportion to the amount of distress that they're having. But that sedation could go all the way to unconsciousness if that was what was needed to relieve the suffering. And then the bottom two options are probably the most controversial: physician aid in dying, or it should be maybe clinician aid in dying, where the clinician would, at the patient's request, provide medication that the patient could take in the form of an overdose by his or her own hand. So the clinician is providing the means, but the patient has to ultimately take or not take the medication. And then the final, voluntary active euthanasia, is when at the patient's request, the clinician not only provides the means, but actually delivers it. So they would give a lethal injection at the patient's request. Again, much more controversial than aid in dying in the United States, but legal in many places, like all of Canada and many Western European countries. Next slide. So first of all, let's look at what kind of context would need to happen before we start talking about any means to potentially hasten death. So you'd want to make sure people are getting adequate palliative care, because palliative care should be the standard of care for relieving suffering in people at all stages of illness. And sometimes when people are suffering, it's because they're not getting adequate palliative care. So some of the reasons might be that they don't have access to healthcare in the United States. We still don't have universal access to healthcare. So you wouldn't want somebody choosing death because they couldn't access healthcare. The job would be to get them healthcare. We also know that many clinicians are not adequately trained in palliative care. So they may know how to do certain kinds of invasive treatments, but they may not know how to do basic pain management or shortness of breath management. We also have a lot of barriers to pain management. So people are very afraid of opioids. Just say no to drugs are a big thing right now in the United States. So many clinicians don't prescribe opioids because they're afraid that people won't take them properly. And so that might be a good thing in some circumstances, but if you're at the end of life and having bad pain or shortness of breath, you got a big problem if your clinician doesn't prescribe. And then people tend to hold off on offering palliative care or hospice until it's too late. So wait till the patient is actively dying, for example. And if it were offered earlier, they might have had a much better quality of life and might not have problems that they're having right now. And then finally, we really permit clinicians and physicians in particular to not develop expertise in palliative care. We would never allow a clinician who's going to treat sick people not to know how to do CPR or very technical disease-directed therapy, but we allow clinicians not to learn how to do pain management, and that just should not be permitted. Next slide. So when we tell people that we can relieve 100% of their suffering, these are some limits of palliative care that are just not correctable. So the ones I talked about before, we change the system, those problems more or less go away. But these are inherent limitations of palliative care. So when we tell people that we can relieve 100% of suffering, I think it frankly frightens people, because most everybody has seen some people in the face of good care, have some pretty tough situations. And we want to know that the clinician will really face up to those tough situations and work with the patient to find an answer. So and some of those exceptions are inadequate pain management or shortness of breath management, but it's also, if we're going to talk about suffering, it's a much more complicated mix. So there is suffering that's psychosocial, depression or anxiety might be the problem that is uncontrollable, or it might be existential suffering, people who can't make any sense out of the last part of their life, they're ready now. Or they might be spiritual suffering where they can't understand how a caring God could allow whatever's happening to them to happen. So those are tougher things to think that we have simple answers for. Furthermore, some of the dependency and side effects of some of our treatments, like a morphine drip or being bedbound, are just too much for some people. That's what they want to avoid. They're super independent people. And we do allow some people choices. So if you happen to be on a life support, let's say a ventilator, and you say, I'm ready to die now, we allow an open conversation about that and allow people to stop. So people are allowed to stop life support. The message we give as teachers or as palliative care people is say, listen to the patient, they know what they need. But take a patient suffering much more than that, but without a clear life support to stop, we often question the patient. Maybe they're too weak, or they're not strong enough, or they should just toughen up. And that clearly isn't fair. And then finally, sometimes our physical symptoms are just uncontrollable. So even with expert pain management or excellent whatever kind of management the symptoms are, there's going to be a small percentage of people who have uncontrollable physical symptoms, and they may say, you know, this is more than I want to tolerate. Next slide. So if you take a look at a state like Washington, where physician-assisted death is legal, what might some of the motivations be for seeking a hastened death? So sometimes, and this is a study by Perlman and Starks that looked at a large collection of people who were asking these questions. And a lot of them were having illness-related experiences, feeling weak and tired and uncomfortable, loss of function, pain or unacceptable side effects of pain medication were part of the equation. And then the second grouping was a threats to self. I can't make sense out of this. Who I am now doesn't make sense to me. I want to be in charge of this. I want to be in control. And many people have had long-standing beliefs in favor of hastened death. So there are whole support groups and national organizations that for people who have views and values about wanting to control the end of their lives. And then the third group would be fears about the future. So I'm okay now, but I'm really worried about the next stage. So I'm worried about what the quality of life will be as I'm dying. Maybe I've had a family member who died badly, and all I can think about is what happened to my dad or my mom in those circumstances, and I just can see that happening to me, and I don't want any part of that. And then the third grouping would be, I don't really want to be a burden on my children or my spouse. If I'm this sick, I'd rather just allow myself to die peacefully now and take that burden off of them. And those are all things that people are thinking about as they wonder about whether they can have a hastened death. Next. So part of this is reassurance about the future, trying to imagine what things will be like in the future. And this is very common. So if you take a look at people who are getting sick, or people who are even older, people like myself, who are thinking about the future, they might want to know, what are my options if I do get in that circumstance? And do I have a guide and a partner? Who would be my medical partner? Do I have a doctor or a nurse practitioner or somebody who can work with me in this, who's not afraid of these questions? And in point of fact, people will explore these things. So if we could teach our clinicians to ask questions like, what are you most afraid of? What might death look like? What have the deaths been like in your family? When you take a family history in medicine, we often learn what diseases ran in the family, but we could also ask, what were the deaths like in your family? And believe me, these are questions that many people would be eager to talk about, because they're very profound experiences for them. So those who have had a worst case scenario, sometimes somebody says, well, my dad died in severe pain and the doctors were afraid of giving giving him pain medicine, I must say, as a clinician, I breathe a big sigh of relief when that occurs, because, I'm not afraid to give pain medicine. I'll give you as much as you need. So that's one you don't have to worry about. But if they say, he died of severe shortness of breath, or he died of, he was psychotic before he died, he was very delirious, and that was horrible, a little hard to be simply reassuring about that. But if I can convince them that I'm not afraid of addressing those things, then they are then free to worry about other things and spend their precious time and energy on other things. Next slide. So the tougher group, so the worrying about the future is a big group of patients and families. A smaller group is the people who are really ready now. So these are sick people who say, I'm ready to die now. And the first step in that evaluation is, why now? Tell me what makes your situation most unacceptable. What ways of addressing your suffering have been tried? Are they getting adequate palliative care and hospice care? Are they getting the best possible treatments available? And we're looking, there's sort of a differential diagnosis of these requests. So sometimes it's uncontrolled symptoms, in which case we redouble our efforts to relieve those symptoms. Sometimes it's a psychosocial problem, which we try to work with the family, for example, to see if we can better address. Sometimes it's a spiritual crisis or religious crisis, and we might bring in a chaplain or somebody from their faith tradition to see if that would work. Maybe they've gotten depressed and they're not seeing their situation clearly anymore, in which case maybe redoubling treatment of their depression or some kind of therapy might help. And it might be dread that they haven't talked about, things that they're really specifically fearful about that maybe talking about will help. So we're going to try to find ways of addressing these things short of helping somebody to die. But it also may be that they are experiencing uncontrollable, intolerable suffering that's either physical or psychosocial, in which case we have a tougher situation on our hands. We have to figure out how can we respond to those circumstances. So we're trying to look for things we can fix, but if we can't find that, then what options do they actually have? And again, so we're trying to look at some safeguards. These safeguards are all trying to be sure that people are getting adequate palliative care. So we want to make sure that palliative care is offered, want to make sure they're getting good informed consent about any decisions that are made, want to make sure we understand what their illness is and what options there are for treatment. And if it's a complex illness, even if it's not, we'd want to get an independent second opinion. So maybe I have a blind spot in this area for my patient. Maybe somebody else will have a different view. And we might want to have somebody, if the clinician caring for the patient doesn't have expertise in palliative care, we might have somebody with expertise in palliative care, because maybe they could find an angle that would help. And then clearly we want to document what we're doing. So not under shroud of secrecy, ideally, but out in the open so that we can really justify why we're making these kinds of decisions. So what about VSED, voluntary stopping in eating and drinking as an option? When might that be an option at the end of life? So the main elements of voluntary stopping eating and drinking is that it requires a really informed patient decision. So this is really puts a lot of burden in a certain way, but responsibility on the hands of the patient, which is not a bad thing necessarily. So the patient must be physically capable of eating and drinking, and they must be cognitively capable of not eating and drinking. So it takes a certain amount of willpower and cognition to be able to not eat and drink when you have a desire to eat and drink. It requires a lot of patient resolve, so you have to be very strong-willed to do this. The process usually takes 1 to 2 weeks. It can be a little shorter, or it can be a little longer. The key factor is you have to not drink. So not drinking is the hardest factor, and it's the most important factor. It theoretically doesn't require a clinician involvement, but it probably should in terms of the evaluation. And then the symptom management as the process unfolds. You need to have somebody with expertise in symptom management, because without symptom management, it becomes even harder to do. So some pluses of voluntary stopping eating and drinking. It has a defined beginning, a middle, and end. Generally lasts 10 days to 2 weeks. It has a built-in check against impulsivity. So on a bad day, I can think I might want to do this, but I'm going to really have to sustain this to be able to carry it through. And so to sustain it, it's going to take me doing this day after day and that's a requirement. It also, the time frame, even though it seems a little daunting, allows time to work on issues of life closure, saying goodbye to your family. Families come together. They have visits and tell stories and do all the good things that sometimes we've learned from hospice can occur. And VSED allows for that to occur because there's a time frame, and you're really pretty capable of doing that at the first part. So at least it allows time for meaningful goodbyes. It does not necessarily require direct medical intervention, but in my opinion, clinician presence and participation is generally indirect, but they need to be present for the evaluation, the preparation, and then the plan, and then also the symptom management as the process unfolds. Some negatives of voluntary stopping eating and drinking, and this may not be a negative, but it doesn't necessarily require a terminal illness. So you're really not dying of your terminal illness. You're dying of not eating and drinking. You're really dying of dehydration. So the prognostic criteria beyond a terminal illness, if we're going to move it upstream, are not necessarily all agreed upon. It's also potentially available to those with psychiatric illness. So again, would we allow somebody whose illness was anorexia nervosa, an illness that is all about eating and drinking? We would never allow this or support this probably in a patient with anorexia nervosa. It doesn't necessarily require a clinician involvement, but it probably should in terms of the evaluation of why now, so that we really understand the driving factors for a patient getting into this. And some clinicians would refuse involvement. So this, if you have strong views about not helping people to die, assisting in suicide in any form, then you're not likely to be able to support this as a clinician. And other family caregivers may support this, but they may also undermine it. So if a family members are not on board and they're forever offering you sips of water or treats to eat, that would be very undermining for somebody who's trying to stop eating and drinking. There are also some legal issues underlying this, although legally it's probably the least problematic of many of the options at the end of life. And some of these thoughts came from Thad Pope, who's a colleague who is a lawyer involved in these discussions with us. So again, some legal caveats. It's almost never directly legally prohibited. So there are no laws to say that you can't do this in the United States. In fact, there's almost no laws in either direction. There's no laws to say that you can, and there's no laws to say that you can't. So the legal risk assessment is that particularly for patients with full decision-making capacity, it's very low legal risk, and it's similar to the right to refuse medical interventions, but this is not necessarily a medical intervention. So do you have a right to refuse non-medical interventions? And again, there aren't laws to guide this, so when there aren't laws, does that mean it's legally permitted or not? It's not assisted suicide from a legal point of view. So again, that would involve taking a medication that would be given by somebody. And it's not elder neglect or abuse, provided the patient has capacity. If you were not to feed or provide drink to somebody who was terminally ill who didn't have capacity, that would be potentially elder abuse, right? But if the patient's making this own decision, then it would not be elder abuse because they're making their own decision. And in fact, trying to feed them against their will might be considered a form of elder abuse. So the risk is very low, particularly if it's part of a broader treatment plan, ideally a hospice plan of care. So once someone starts eating and drinking, starts stopping eating and drinking, then they becomes eligible for hospice, even if they weren't terminally ill, because they are dying now. And this can then be supervised by licensed health professionals. So what if now later on in this process, sometimes people lose capacity. So again, and when you lose capacity, you may lose that willpower to not eat and drink because you're pretty darn thirsty. So reminders are probably legally permitted in that circumstance. So we can remind somebody that they're trying to stop eating and drinking. And if they then can not do it, then it'll be okay. And then if they really can't do it, then we may still provide the comfort-oriented refeeding if the request to eat and drink really persists at that point. So what about stopping eating and drinking after capacity is lost? So a lot of people would say, well, I want to keep living as long as I have capacity, but when I lose capacity, that's when I want to start it. And you might spell that out in your advance directive. There might be, if you spell it out clearly enough, then the family and caregivers would be challenged with that once you lost capacity. Does this mean we shouldn't give him or her something to eat? And again, clearly we could do that in terms of artificial hydration nutrition. That would mean you could clearly refuse a feeding tube and it might even also include assisted feeding. So of having people put a spoon in your mouth, but ordinary feeding would be a lot harder to restrict in that way. So again, we might be left with only allowing comfort-oriented feeding and comfort-oriented self-feeding perhaps. So comfort or interest-oriented feeding of incapacitated patients should be the standard if capacity is lost. And if you have set out this kind of hope in your advance directive, then you want people to struggle with this and maybe you'd be able to pull it off, although I think it's complex. What about psychiatric issues involved in this? And again, these thanks to Linda Ganzini, who's a psychiatrist on the West Coast and who's thought a lot about these issues. So some psychiatric issues, clearly we want to know if somebody has decision-making capacity before they start. Can they express a stable choice? Do they understand what they're doing? Do they appreciate the information? Are they using reason and logic? Do we know why they're making this decision? And capacity is not an all or nothing thing. So capacity is often around a particular decision. So can they make sense out of stopping eating and drinking, which is the key decision here. So they may not be able to balance their checkbook. They may not be able to do some other things, but if they really understand this particular decision, then perhaps they could still make it. Psychiatric disorders may or may not impair their capacity. So they may have had some psychiatric disorders in the past. And the question would be, does that impair their capacity? And you'd clearly want, if somebody had a psychiatric disorder who was making a decision like this, you'd want to have an experienced psychiatrist evaluate them to make sure this was a rational decision for them. And again, if there are questions about cognitive impairment, then a psychiatric opinion would be a good idea before this process was started to make sure this was a sound patient decision. So delirium is likely late in the process. So people are, as they get really dehydrated, most people will get some confusion. And again, that should be anticipated and talk about how it should be treated. And it should be treated aggressively. So if people are agitated, we could certainly give them sedatives, things to help them relax, help them sleep. And we'd want to have discussions about this in the early going. So we have agreement with the patient and family about how we're going to approach these things. This can get difficult for families who are trying to support a patient during this, particularly if they really want to eat and drink. And we sort of have to try to think through in advance and work through how to approach that if it happens. And again, psychiatric consultation, if decision-making capacity was uncertain at the outset, we'd want a psychiatric opinion. And again, if they had a major psychiatric disorder at some point in their adult life. Next slide. So we're also asking the why now. Many people are thinking about this hypothetically down the road, but then they may want it at a given point in time. And we're going to ask, why do you want it now? Make sure we understand that. And then the small number who want to activate it, we're going to ask the why now again. Why are they activating it now? Are they sure that they want to? Are there areas of unrecognized or undertreated suffering that might be better managed by addressing the suffering than by stopping eating and drinking? And again, getting a second opinion if we're not sure. Now, ethics, we'll have to look at ethics and look at law a little bit in this area, but ethics in this case is probably more important than law because there aren't really laws to guide this practice. So thanks to Bob Trug, who is a ethicist from Harvard, a clinician ethicist, for these questions. So do patients have a right to refuse eating and drinking? That would be an ethical question. The answer to that is yes, that there's no, because the alternative to that would be force feeding, feeding somebody against their will who had capacity to make such a decision. And that would be barbaric and harsh, and most people would say that that cannot be done. Is it morally acceptable for patients to choose to stop eating and drinking? And you'd get some mixed answers to that. Those who would say no would say any choice to intentionally hasten one's death is suicide and therefore is morally wrong. The patient's not dying of his or her underlying condition. They're motivated by the burden of staying alive, and the intent is clearly to end one's life, which is not permissible from one point of view. From another point of view, it may be more acceptable to choose death depending on one's circumstances. And we do know we allow this under some circumstances. For example, if you're on a life support, you're allowed to stop that life support. And quality of life issues may be really very relevant in decisions to stop life support. If your quality of life is good, you might go on and continue with the life support, consider somebody on dialysis. As long as they're enjoying their life, they're willing to put up with the dialysis. But when their quality of life starts to wane, maybe they'll want to stop their dialysis. And we say that's permissible. And there may also be different kinds of suicide. There may be suicide from mental illness, which we're going to try to prevent and treat the mental illness. There's also suicide that's heroic. Jumping on a bomb to save your crew in war might be a kind of suicide. And again, in this sense, a heroic might be trying to spare your family the burden of your care for the last part of your life. And then rational, might there be some circumstances where it is rational to make a decision like this? Is it okay to provide palliative care to patients who are choosing to stop eating and drinking? The answer to that is probably yes, that clinicians have an obligation to provide palliative care to all patients who need it. It would be analogous to providing palliative care to somebody stopping a life support, although some would say that providing palliative care to somebody doing this, if you feel the practice is immoral, then that would make you complicit in an immoral act, and you would conscientiously object. Now, again, you could conscientiously object, but then another person might step in and take over that role. So again, you might be able to find somebody who thought it was permissible. And then should we make patients aware of this option, even if they don't know about it? So part of the one answer would be yes. If patients are asking about options to hasten death, it seems unfair to have them have to discover it on their own. And in particularly if they live in states like many of us do, where physician-assisted death is not legal, we're really, if we wanted that option, we might be really searching for other options. And again, if the patient's asking about these things, I think we should have an obligation to tell them about what options might be available. And some would say that we should not tell people about this, even if they were asking about options, because it might imply an endorsement and it would encourage participation. If you felt that was an unethical act, then maybe we shouldn't tell people about an unethical act. And again, we can probably have a debate about this question. Next slide. Other questions, should it be available to people who have already lost capacity? And I think the simple answer to this is no, although we could get some debate about this. Other options such as palliative sedation might be considered, stopping life supports, but voluntarily stopping eating and drinking requires voluntariness, and you've lost that if you lost capacity. So the default should be then comfort-oriented feeding, and it might be the minimal amount of comfort-oriented feeding if we really feel a patient would want to stop eating and drinking if they could control this situation. And again, this would be a circumstance if we were thinking about these where a formal ethics consultation might be helpful if we were uncertain. So again, who are the best candidates for stopping eating and drinking? These would be very disciplined, control-oriented patients, probably like a lot of us, by the way, who are on this call, without a high degree of symptom burden. If you had a really high degree of symptom burden at the time you're thinking about it, it's probably too slow, although you could combine it with aggressive palliative care. If you are ready for death that is coming too slowly, that would probably be a good candidate. So you're saying, I'm ready now, and this would be a way of speeding the process up. And you'd need a supportive family who agreed with the decision. So you'd have to have a conversation with at least your immediate family, because they're going to have to make sense out of this. Who, if anyone, should be told about this option in advance? And again, maybe all seriously ill patients who want to know what their options are. Certainly people who are asking about assisted dying, perhaps if they live in a state where it's not available, but even if they live in a state where it's available, this might be a preferable option for them. Perhaps only those who are dying badly despite good care. Again, that would be a very narrow group. And again, if we tell people about this option unasked, might that seem coercive? Might we be suggesting that this is a good option for them? So I'm not sure that we should tell everybody about this, but certainly people who are asking about what their options are. And then the clinical mandates, if we're going to do this, we want to make sure that we have tried all traditional symptom management strategies. We want to try to find the least harmful of all the last resort options that I showed earlier. We're going to try to get a second opinion in cases of uncertainty, whether it's our uncertainty or the patient's uncertainty. We're trying to find choices that respect the values of the major participants, that allow for informed consent, engaging family participation as the patient allows. And then you're going to prepare a start date. You try to bring families together and have a meaningful time for while the patient is still interactive, a good time for saying goodbye, get hospice involved, figure out where it's going to occur, and set up backup plans. Okay, so now I'm going to shift gears and talk about two cases, and we'll walk through them and think about what was involved in this, and think about whether it made sense. And again, you can take notes about whether you think this would make sense from your point of view. So the first one was a man that I took care of who had breast cancer. Now, breast cancer is very unusual in men, but does occur sometimes. This man, at the time he was first diagnosed, had some treatment options available to him. So he was wanting to start treatment, and we were planning on some surgery and some chemotherapy for him. But he also wanted the down the road question. So he was asking, well, what are my options down the road? And he was somebody who felt very strongly about wanting to have the option of assisted death, physician-assisted death, like a medicine he could take as an overdose. So he asked me whether I would provide that. And at this time, I had written about this subject, and I was sort of a subject of this in the community. So it was something that I probably couldn't provide for him at that point, because it is prohibited in the state of New York. So we were going over what other options he could have. And the option that we did discuss was he could stop eating and drinking if he chose to do that at some point in the future. And he thought that was barbaric. He thought that was cruel. It was awful. He couldn't imagine doing that. And he was extremely angry that he couldn't have the options that he wanted. And so I think you can show the next slide. So now fast forward, he was trying treatment. We continued to meet, tried treatment, and 6 months later, his disease is now very progressed. So he's got cancer throughout all of his bones. He had fractured both of his legs. And in point of fact, he's in our palliative care unit over at Strong. And now he says, I'm ready to die now. And again, we revisited the fact, and even though in the secret world of physician-assisted death, if he were at home, doctors can take a risk of underneath the radar screen providing medication that could be taken. He's now in the hospital, not at home. This is not going to happen. And also, I'm not a person who can prescribe that right now, because I'm too vulnerable in that sense, because I've been public about this issue in the past. So we again revisited the possibility of stopping eating and drinking. And he again lamented, was extremely angry, but also recognized that that was the only option there was. Now, again, if he was having severe pain, we could have given him very high pain medicine, but if he didn't move much, he was not in a lot of pain. He was distressed, he was anxious. We could give him anti-anxiety medication, but not to the point of unconsciousness. So stopping eating and drinking was his choice, which he chose to begin. So he said, I'm not happy about this, but it's the best of all the bad options that you have for me. And in point of fact, he did this, and he was a very, as many people are who want these options, a very controlled man, and he was able to not drink, and gradually became weaker, and eventually died on our palliative care unit about 14 days after being admitted, after he stopped eating and drinking. Now, again, his family came together. There were good times for goodbye, but he was not happy about this choice. But he was also relieved that he at least had an option, which he would have not otherwise had. So next slide. So this is a woman named Phyllis, who also was the mother of one of our palliative care doctors. And she had dementia. She had early dementia. She was worried about, because the signs of dementia were happening to her, worried about what options do I have down the road. And so her son, who was one of my colleagues, didn't want to be the doctor to his own mom. So he asked me to provide a consultation for her. And so I visited her at home and talked with her about her situation and her wishes for the future. If you put on the next slide. And her wishes for the future would be to, she wasn't sure she was ready now, but she definitely didn't want to go through the late stages of dementia and didn't want to lose capacity. So she knew she had to act while she still had capacity, but the timing of this was very tricky. So we decided to meet regularly to try to figure out when is the right time to start this. So if we start it too soon, she's going to miss out on very valuable time. And these are pictures of this valuable time where she's doing some of the work of saying goodbye with her family, telling them how much she loves them, spending meaningful time with them. And she was doing all that work that you hope people will do on hospice. And she was doing this while she had capacity to do this. So we were hoping that she would maintain enough capacity to make this decision, but the timing of it was tricky. Again, would she have wanted an assisted death if it were available in New York? I'm not sure she would have. She might have, she might not. But it probably wouldn't have been available to her because she wouldn't have been terminal enough. So in places where it is legal, it has to have a prognosis of 6 months or less. And I don't think she had that qualification. So we're trying to find an option for her, given these unique circumstances that she had. So show the next slide, please. I think this requires. So this is a sort of her disease progressing, and these are some of the meetings over time. Picture there is of her son, who's again my palliative care colleague, as they were finding their way through this process. And she was having a very meaningful time with hospice care, sort of saying goodbye and hoping she could get the timing right of this, and worried that she might wait too long and wouldn't be able to carry through with it. And the next slide. Oh, go back to that again. So eventually, she did stop eating, and completely. And as she did do that, she became gradually more weak. And again, these are some of the pictures of her later phase, and the one in the lower left-hand corner would be at the very end as she's getting a lot weaker and not eating and drinking anything. Now, again, she would get a little thirsty sometimes, and there's a technique during this where you take a little bit in and swish it around and spit it out. But with a little reminding, she would remember that what she was trying to do, and she was able to stick with it. And she died a very peaceful death, again, over about 2 weeks. And everybody felt good about this. She had this beginning, a middle, and an end to this process of saying goodbye. So next slide. So So now we're going to pause and have, these are some references that you might be interested in, and will be, I think they're available to you. We do have a book coming out about stopping eating and drinking that's going to be coming out in the spring of this year that will have all these clinical, ethical, legal dimensions of it, along with some patient stories. So that might be something of interest to you all. And I think the next slide, or if there are no more slides, then we're going to have now questions and answers, or at least questions. I don't know if I'll have the answers, but I'll try.
Thank you so much, Tim. So time for discussion. So I'm going to open the text chat now and see what questions you have. So let me just scroll up here one moment. So Jean Parker asks, is there any data regarding the percentage of terminally ill patients who choose to VSED in the US generally or specifically in palliative care units? And just a note for everyone, if you're comfortable raising your hand in the participant list and asking your question on camera, you're welcome to do so. If you choose to stay more anonymous, send it via text chat. So Tim, your thoughts on the percentage?
Yeah, I think the percentages by and large are not known. I think because what we do know are some of the case, there have been some case series. There's a particularly good one written by, I think, Linda Ganzini in the state of Washington, where they did a collection of these cases. It was a few percent, but you don't know how frequently it happens because a lot of people don't want it known that that's what they did, because if you start asking questions, then people might weigh in and say that it's not permissible. I'm not going to support this. So there's a lot of uncertainty about its legal status, which makes it very difficult to study reliably. But it's probably a few percent, maybe as high as 5% in some studies. But again, the studies where people admit to this or are willing to talk about it are probably overestimates compared to how often it really happens. Now, again, the gradual stopping eating and drinking, the natural part of losing interest in food and drink, that's really common. And not pushing food on people at the late stages of hospice, that's really common. Let me just hit this. There we go. Sorry. But we don't really know how common it is.
Okay, thank you, Tim. So the next question is from Karen Lieberman. She asks, how do you square VSED with hospice philosophy against hastening death?
Well, hospice says neither hasten nor postpone. So there are things we do on hospice, by the way, that do hasten, right? Like we take people off life-sustaining therapies, right? That if we take somebody off a treatment that is likely to prolong their life, are we hastening death? We probably are. Now, is it our intent to do that? Well, it depends on, does it have to be not your intent? It's probably the patient's intent to hasten things if they're going it with their eyes wide open. It should be my intent. I should be aware that I'm doing that if I'm doing it. But I do think the notion that we should never hasten death, we have in medicine learned how to prolong life a lot, which is generally a really good thing, right? And when we're prolonging quality life, that's a great thing. But there's also this prolonging suffering life. And that's maybe not such a good thing. And the probability, with our abilities to prolong life, the probability of people experiencing hard suffering toward the very end tends to go up because the opportunities to die quickly and easily, which we can easily prevent, are gone. So then by the time we stop treatment, usually we've gotten into a tougher situation. So we have a lot of challenges about whether we can hasten death, particularly after we've done all these things to prolong life. And again, we can have a debate about this, whether that should be permissible or not. But I think if we are going to prolong life in the way that we do, and that is, I think, generally a good thing, we really have to face up to some of the situations that we have created of people experiencing bad suffering at the end of that process.
So Ashley Sweet asks, could you speak more about what symptoms people might experience in particular when they are stopping eating and drinking, and what palliative treatments are available to address these symptoms?
Yeah, it's a good question. And of course, the big number one a symptom is dry mouth. Because if you're not drinking, you get dry. Those of you who've been dehydrated, perhaps you've had the flu and not been able to drink much, you get pretty dry and it's pretty uncomfortable. So the way to address that symptom, there is a artificial saliva, which is a sort of a medical thing, or you can just take some kind of liquid that the patient finds palatable. You put it in the mouth, you swish it around, and you spit it out. Now, if it's sipping of this, so if you take a little bit to relieve the shortness of breath and you sip, 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 what happens is it really goes on a long time, like it's many weeks, maybe even many months. So it's very problematic, and I think it's probably not. If that's what your plan is, then that should be the plan, but it's not stopping eating and drinking, and you shouldn't anticipate it's going to happen quickly. What other symptoms? So weakness, as you get dehydrated, you're going to get weaker. As you get dehydrated, you may get confused. So you ought to anticipate that. Now, again, if it's agitated confusion, we can provide sedatives for that. If it's pleasant confusion and you're really thirsty, we ought to think through how you want us to respond to that. Do you want us to provide a one-time or every once in a while a little bit of liquid? Do you want us to provide reminders about that you're trying to stop eating and drinking? Again, all those are very reasonable things to do, but it should be thought about in advance because it's very likely to occur. Need to think about where it's going to be. So if it's going to be at home, at first maybe you could be by yourself, but after a while you're not going to be able to be that. You're going to get very weak. So you need to have other people around, and that's part of what you want to have in this process. Because the good part about this is there's a chance to come together as a family, but you're coming together for 2 weeks. You're not coming together for 6 months or a year or 5 years to care for somebody. You're coming together for a very short period of time. And that can be very meaningful time. It can be very challenging for families to do that in the modern world. I'm not minimizing that, but that needs to be thought about. Or you could pay for people to do that. So some people hire paid caregivers, or there might be hospice workers that can be hired to do that. And we found lots of different ways to allow this to occur and to find people to provide the support if a family couldn't do it, or if somebody didn't have a family.
So I'm going to combine questions from two people. So Micheline asks, can the patient combine palliative sedation with VSED to manage hunger and thirst? And then Barbara Sarah asks, do dying patients actually experience hunger? And at what point, I would add, does hunger drop off as a symptom that they experience?
So if you stop eating and drinking, hunger drops off pretty quickly, because when you don't eat, the body generates ketones. And ketones are a way it's a sort of a mechanism to generate fuel for the body, but it also takes away some of your appetite. So in point of fact, hunger disappears generally within 24 hours or maybe 36 hours. Thirst does not disappear, so you have to treat that. So that you have to anticipate and try to treat. And these things all should be anticipated and thought through in advance. I think there was another part to that. Was there another part to that question?
From Micheline, can the patient combine rather palliative sedation with VSED to manage thirst and hunger symptoms?
Yeah, I think that it's an interesting question. So I think you'd have to talk that through. So if you're really thirsty, would that warrant sedating you to unconsciousness, for example, or sedating you a lot? And again, I think you'd find some differences in opinion about that, whether that would be permissible. I think you could, certainly if you became delirious, I think sedation is a very appropriate response. I think some sedation might help people deal with the thirst. And then you could gradually, proportionally ramp it up. I think that would be a reasonable approach. I think this would be something you'd want to talk through with the clinician, the main treating clinician who you're working with, because there will be some differing opinions about that, how much sedation could be provided.
So Randy asks, how have you experienced hospice interaction and support of VSED? I have experienced mixed opinions from various hospices. So in Randy's opinion, they have experienced mixed opinions. So what are your thoughts, Dr. Quill?
I'm going to agree with Randy and say it's mixed opinions. And I do think that would be if that was important to you to have that option, and you were thinking about going on. Let's say it was important to you to have that option down the road. You're going on hospice now, but you said, at a certain point I may want to do this. That would be important to interview the hospice. Say, how do they, down the road? Be honest with it. It is a time for honesty in the early going, because if there are hospices that are fine about that. They see this as a very permissible thing in our community. There are hospices that will allow this. I think probably both would allow it by and large. But it's good to check it out in advance if it's important to you to have that option, and to make sure that they would support it, because it's very hard if you've developed a relationship with hospice. You have your caregivers coming in, you get close with these folks, and then maybe having to change programs and caregivers later on. That would be a hard thing to do. Now, again, it's not just the hospice program. So there may be aides that you're working with also who may or may not be able to support this. So we've certainly had aides who were very uncomfortable when somebody was starting this, even though the leadership in hospice were comfortable with this. So there may be a need to change aides, or at that point for family to take over a more central role in the caregiving.
So Lou Cohen asked, are there any other special considerations in cases involving dementia like Alzheimer's disease?
I think Alzheimer's disease is one of the toughest cases, so again, I think the case that we presented is a good illustration of the timing question, which is very hard. So the wanting it down the road, I think, is pretty easy to assess. But as somebody is getting closer to experiencing significant dementia, actually activating stopping eating and drinking is much more tricky. I think this would be a time, if there were a lot of questions about capacity, that if you happen to have a good psychiatrist who is comfortable in this zone, like Lou Cohen, who is a rarity, I must say, I think that would be great to bring that person in to help in that assessment, because I think it is difficult. So again, this may have people have to make the decision earlier than they would really want to do it, because, and I think there may be good reasons to think about that, because I think it puts a much higher burden on families to decide, gee, they were ambivalent about it, let's say, because they hadn't activated it, and now they've lost capacity. And how do we know they wouldn't still be ambivalent about it? And so that you lose that anchor of the patient finally making that decision for him or herself, and that's a big anchor to lose. So in that case, you want to see if you can refine it, or get as many opinions as you can about people who are comfortable in this zone.
So Stephanie Gonzalez asks, often families of patients without capacity are aggressive about continuing artificial nutrition and hydration. Would you offer VSED when you feel artificial nutrition and hydration prolongs suffering despite family objection?
Well, I would say if you're struggling around stopping artificial hydration nutrition, now just to reiterate what that is, that's usually a feeding tube, right? So if you're struggling with stopping a feeding tube, which is a medical treatment, then I think you're going to have, if families really are getting very distressed by that prospect, then stopping eating and drinking when you're capable of eating and drinking is a whole nother kettle of fish. I think that's a much tougher decision. And again, now if a patient's making that decision, they can articulate their views and values themselves. But if a family's making that decision, I think it's a lot tougher. These are by and large patient and family decisions, though, particularly of the core family. Now, again, I know probably all of you come from model families, but my family is a little more complicated. So I'm not sure I'd want everybody in my extended family to weigh in on my own decisions at the end of life. But core people, my wife, my kids, you'd want to make sure they're on board and that you talk it all through with those core people, and the other people, keep them out of it by and large.
Thanks. Janet Simpson asks, when a patient attempting VSED loses capacity and the family steps up to stop the process, is there any legal protection for the patient and her wish to follow through on these desires, given the uncertain legal status of VSED? Asking this question from New York State.
Yeah, that's above my pay grade to answer that question, unfortunately, because I'm not a lawyer. But I think you don't want to be the test case in these kinds of cases. So for that particular, unless you wanted to be a test case. Now, some people, that would be part of their legacy, for example, to be a test case. So I feel so strongly about wanting to have this option. I want to challenge the law. Now, the danger of challenging the law is you can get an answer that you really don't like, right? So right now we have an answer that we can live with and work within, and there is no prohibition on this practice. And you could theoretically, if you were really to test it, you might end up with a precedential case that would say this is now not permissible in New York State, and that would be a much worse situation than we're in now. So again, I'm not sure that you want to go get into the legal system around this if you can avoid it. But this would be my personal point of view.
So I see that Joel and Barbara Sarah raised their hands on the video. So I'm going to call on Joel first and then Barbara Sarah. Joel, I'll unmute you and then please go ahead.
On my audio, here we
There you
go. Hi, Tim. I'm Joel. I'm living in the mountain country in Arizona. This institute here is called the Life Completion Institute. And I talked to Sarah via email and said I had questions about exactly what the goals and directions were of this organization that we're affiliating with. I'm in the end of my 9th decade of life. The lurker over my right shoulder is spouse Frances. She has a medical background, many lifetimes to go as a registered nurse, and I was a clinical psychologist. I had a career in the military, which gave me many opportunities to experience death at close up. So I look at the life experiences, life completion, and saying that a little bit different than the medical view of life. We have George Saunders, who was a movie actor in my generation, who committed suicide, the big S word, and his suicide note said, "I'm bored." He saw his life as completed. There were no medical interventions. There were no diagnoses to bring him to that. And at the very back, I'm going to go a little aside at the end of your last speech. You talked about your family not all being in tune with you. And I recall the quote by Marcus Aurelius, which was, when you're lying on your deathbed and you're seeing all those people sitting around and grieving for you, realize that at least 20% of them are happy this is happening. And so there we go. So here I am at getting close to the end of my life. I have less future than I have past. I have one or two things that I feel I have to do yet. I'm motivated for. So my life is not completed yet. So here we are grouped together as the Life Completed group. Where everything we hear about death and dying seems to be tied into the medical model. I've talked to my physicians teams, and I've got perhaps 50% acceptance of my position that I want dignity in my life, and life is at all costs is not part of my priorities and criteria. And so I'm willing to accept my mortality. I'm willing to accept a dignified death. Now, I'm sort of, I don't want to say I'm rambling right now, but I want to leave this to an open conversation, not that you can get off with a yes or no answer. But as you see my condition, who hasn't come to life completion yet, doesn't have a rock hard physical diagnosis that says end of life is imminent within 6 months or whatever the rules are. In Arizona, we do not have MAID. We do not have these things. So there's my issue is that here we are as life completion. I'm hooking on those two words, as I mentioned to Sarah in my email. And how do you see your presentation, your wisdom, your experiences, not as a medical man making diagnoses, but as dealing with people who just said, I'm bored?
Yeah, I think it's a good question. I do think having the possibility of a way out for someone in your circumstance, first of all, would be very reassuring. So if you're bored, but you're still finding some things, that keep you amused or keep you going at this point, right? So you're I'm worried about down the road in case I really run out of things that are meaningful to me, right? And it may not be a terminal illness that brings that. It may just be life that's just gone on too long, and I'm tired of life. And I do think, and so if you lived in a state that had medically assisted dying, you wouldn't qualify, period. And you probably wouldn't qualify from a prognosis point of view, and you wouldn't qualify probably from a suffering point of view. But if you, from a life completion point of view, the sort of the theme of this series, you might say, I've really completed the things I want to complete, and I'm ready now. So, and I actually think in your situation, the situation you're describing, this option, stopping eating and drinking, would be the main viable thing that would be available to you. Now, again, maybe you're on medicine that's life prolonging, maybe you're on a lot of stuff that you could stop. You could stop all that stuff at the same time, but it probably is going to be stopping eating and drinking. And it might not be a bad choice, because you would then be able to review in your very long life all the amazing things you've done, and have yourself and other people around you enjoy that, with the knowledge that you're going to be gone in 10 days to 2 weeks. That would be quite a vibrant time, and it might work very well for you. I don't know that it would, but it might. And it is clearly your choice to make. And that's one of the pluses of this option for someone in your circumstance.
Yes, but I would think it's almost impossible to go through the process without bringing the medical professionals into this, the process. What I read about it is that after a period of time, and I have gone through prolonged hunger and starvation in survival situations, not so much with the dehydration, that there would be palliative care people that may have to be brought in. There would be nurses, aides when I become incontinent. I can't see where we can untangle ourselves from the medical industry.
You probably would not be able to, but if you found the right person to work with you, wouldn't be the worst thing in the world, because it provides some support for you and also for your partner, who'd be trying to support you through this thing. So again, it's not necessarily bad to have other people involved if you have the right people involved. You have to work that out up front. And I think by talking with people up front and getting the right people involved, I think it could happen.
Yes, and I believe that's good wisdom for say the people in this group, because in my conversations, I don't know if I was more forward than you. I looked my doctors right in the eye and I presented them with a letter giving them my philosophy, and found I was surprised. I had an internist that was with me for some 16 years who says, I can't support this. Mm-hmm. And I started talking about the dying process, and he says, oh no, he says, as soon as you become eligible, he says, I step out of the picture.
Right.
I said, we've been together for 16 years. You know me better than any other medical profession. You're telling me you won't be there when I need you at the end of life? He says, that's right. He says, the hospice doctor's in charge, or the hospitalist doctor is responsible, or the palliative care doctor. I said, who are they? He said, I don't know, whoever walks in the door.
So what you're giving, and I'll close out this segment with this, but what you're giving is really good advice for people who are interested in these subjects, is to talk to their main treating doctor, tell them your philosophy, even if it's quite down the road. And if they're completely on a different page, it's probably time to find a new doctor. Because it's so critical that the clinician's doctor, and it could be a nurse practitioner. I mean, it doesn't necessarily have to be a doctor, but it's got to be somebody who's in it for the long haul, who shares your philosophy, because it's your philosophy that counts. But thank you for sharing that. That's a really important story.
Yes, I believe that's your wisdom speaking there, that it makes sense for me because of my experiences. However, I identified myself in the early stages of this as being in a rural community in Arizona, and my access to a plethora or a variety of medical professionals becomes limited.
Yeah.
And I don't travel well any longer, and I'm suffering. It seems like each month a little more something comes in to say, Joel, you're getting older. Now, I'm not personalizing this only for myself.
Right.
What I'm saying is what I read in the genres is pretty much the same story being told by people who are dying or wishing to die.
Yeah.
Is that it is not an easy process to do the stop eating and dying, voluntary stop eating and dying. It can become very complicated about a week into the process.
Yeah. And that's why you need a medical partner to do it with you.
Thank you so much, Joel, for your questions. We should move on to other questions, but thank you for your in-depth questioning. Much appreciated. And happy to stick around after the session if you have a follow-up comment or question. Barbara Sarah, please go ahead. You'll need to unmute yourself.
I'm the person who previously asked the question about whether people are hungry. So I have just a short story about my brother who, out in Seattle, he was, he got enrolled in hospice, and he actually began to lose his interest in eating. So in other words, he really didn't have an appetite anymore. But so what his daughter, my niece, did was, in order to stimulate him, she began to read him menus of restaurants where they used to go and eat. And he got so happy. He wasn't hungry, but he was not eating or drinking, and went for 13 days without eating and 8 days without drinking, listening to stories about meals that he had had that made him so happy, and about trips that he had taken to Los Angeles to go to every Jewish deli available. He died happy listening to stories about food.
It's a great story. It's completely counterintuitive to me, but it shows that everybody's unique, and the challenge is to find out what works for them as an individual. And that's a great story that I very much enjoy.
Thanks.
Thank you, Barbara Sarah. If anyone else wants to raise their hand, I only have 25 people on my screen, and I have to toggle back and forth. So please bear with me. I see Judith is raising her hand. Judith Cohen, please go ahead.
I live in California, and I live in a town where, and within, say, 50-mile radius, the hospitals are controlled by a Catholic healthcare system. And we have a major, and I'm in my 9th decade. And when the time comes, it's going to be difficult. I live alone. I have no family. I do have a trust, and I have a successor trustee who will fight for me. But I have to be transported one way or another if I follow through on this kind of end-of-life program. And it's a difficult situation to be in, I'll tell you. I just want to let people know that I may have to leave where I want to be in order to be taken care of the way I want to be taken care of. And it's going to be very, very complicated and very difficult. And that's why I'm hopeful that we've had several, at least 2.5 or 3 sessions with VSED. And I'm hoping that the Completed Life Initiative has other projects or other options and other lunch hours devoted to other subjects. Thank you so much, Sarah.
Very much, Judith. So we will be having monthly lunch hours on the first Thursday of every month. So the next lunch hour scheduled is with Peggy Batten, who is actually here today.
Yeah.
She was one of our speakers in the session 1 of the Completed Life Conference. And then we'll have subsequent lunch hour discussions on other topics. So please stay tuned for those.
Thank you. I was hoping for Peggy.
Great.
So let me tell you briefly about a Catholic nun that I took care of about 20 years ago, who was also in her 90s, and she was ready to die, and so we went through her different options, and she decided to stop eating and drinking, and she viewed and she was Catholic. She didn't view it as suicide. She viewed it as a fast for God. That's how she saw it in her own eyes. And she was able to do this she lived in a Catholic facility. The Catholic facility allowed her to do this. We didn't push the issue of exactly what we're doing, but she was able to do it and died extremely peacefully. So I do think there are, first of all, as you know, Catholic organization, there's a lot of diversity within that group, so that you can often find people who have an open mind to these kinds of things. Now, it may not be completely wide open to all the options, but the stopping eating and drinking part may be an option that is still within the frame for some Catholics, and maybe even a fair number.
So I saw Rosalind raised her hand on camera. So Rosalind, please unmute yourself and go ahead.
Thank you very much. Some years ago, when my husband was dying, hospice provided him with glycerin swabs for mouth comfort. They were like lollipops on the end of a stick. And I have never heard that mentioned for mouth comfort anywhere at any time. And yet it was useful and provided by hospice. What do you know about that?
The glycerin swabs are on the list of palliative measures for dry mouth. So for many people, it's very helpful. And so as with every symptom in hospice, there's a list of things you try, and glycerin swabs would be on that list, and you'd really be looking for whatever fits for that particular person. And if it fit, then you stick with it. It can be very helpful. So thanks for raising that. It's a very important piece of the puzzle, potentially.
Thank you, because it seems that nobody's ever heard of this except me.
Well, now a few other people have heard of it, but it is in palliative care textbooks around treatment of dry mouth. It's on the list of things to try.
Thank you, Rosalind. Toby Myers, please unmute yourself. Go ahead.
What do you know about doulas, and is that movement growing? Because that would seem to involve a quasi non-medical personnel.
Yeah, I have had patients who were cared for by doulas, and it was absolutely spectacular. So they are people who are extremely well trained and committed to caring for people at the very end of life, and particularly in the very, very late stages, the last hours, minutes to hours to maybe days of life. And so finding a death doula, if in terms of making the most meaning out of this process, might be something to look into, to see if it was available where you live. And there is a subgroup of people who do this, and they're amazing people who are very connected to do this and help people explore the spiritual dimensions of what's going on, which I think is a wonderful practice.
So Lisa, has a question in the text chat. I'll go ahead and read her question. She asks, what are the challenges if you are living in an assisted living setting? Have you had anyone complete VSED in this setting? Do you find that communities of care have policies on this in their assisted living or skilled nursing settings?
There probably aren't policies prohibiting this or allowing this. So there probably, and that's the beauty and the challenge of VSED, is that there aren't policies and there aren't laws. I think this can be done in an assisted living setting. I think getting too into the administration of the assisted living setting, I would not be inclined to do that. I would be inclined to get into sort of, this is hospice care, and seeing if you can get caregivers in who might or might not be part of the assisted living setting, because you don't want to become the test case for an assisted living center, I think. Some people might want to do that. And if you have a lot of time, and that's you're contemplating wanting this down the road, then you might want to be a test case in your assisted living. But if you want it now, you don't want to be a test case, because while you're a test case, people are going to be very uncomfortable and maybe not allow you to do it. So I would say, if you wanted this down the road and you have trusted people in the facility you live, talk to them, see whether this is possible. And if it's not possible, then you have to decide, do you do this under the radar screen? It looks a lot like when people are dying, when they stop eating and drinking, right? Because people who are dying stop eating and drinking. It's just not a conscious choice. It's natural part of the dying process. So again, you may be able to fly under the radar screen, and you may not.
So there's a question from Micheline in the chat. She asks, have there been cases where the patient has a guardian ad litem prospectively appointed to ensure that VSED is completed?
The answer is that I don't know the answer to that. I do think if you wanted this in the future and you wanted to wait till you lost capacity, having a clearly appointed person who you've had big conversations with and clear documentation would be the best chance of allowing it to occur. Now, again, it can be very hard, because when you lose capacity, you may really want to eat and drink because you forgot, you can't remember why you made this decision, and reminding you may not work. So it's not a simple process. But I think the best chance of doing that is to have somebody who's clearly identified to be your surrogate decision maker, and have big conversations with them. It's also a good idea if you're doing this now while you still have capacity, because you may lose capacity late in the process, and having that person advocate, both remind you what you're trying to do, but also advocate other caregivers that we need to continue to support what she wanted to do, because she was really clear and went through a lot of work to set this up. And that's very compelling evidence that you really meant it when you set all that up.
Great. So just for everyone's awareness, Professor David Hoffman covered elements of the legal aspects of VSED in November's lunch hour. The recording's available on our website. I can link to it for everyone in the Zoom chat here today. And coming up in February of 2021, Thaddeus Pope, who Dr. Quill referred to in his presentation, who's an attorney and expert on VSED and medical aid in dying, will be talking about the legal ramifications. So please stay tuned for that. Faith Summerfield, please unmute yourself and go ahead. We can't hear you. There we go. Go ahead.
There we go. Okay. I just wanted to respond to the question about VSED in a medical directive or living will. You absolutely can do that. I have it in mind, and you absolutely can put it in your living will. So that's one of the few things you can do legally, but you can.
Yep.
Thank you, Faith. Rosalind, did you have a follow-up question?
One more thing, I want to recommend a DVD, a video called Dying Wish, and it is 29 minutes long, available from Amazon. This video was made by Michael Miller, a retired surgeon who is dying of pancreatic cancer. And he researches his dying process and decides to go with VSED. And he had this video made of his 10-day dying process. And it's not an easy video, but he has a friend who's a physician who sees him through it. And it shows his 10-day process of saying goodbye to his family and retiring to his room, and day by day, that 10-day process. And I highly recommend it. Dying Wish. I think it costs maybe $29 from Amazon.com. I have shown it, I own it. I have shown it many times to interested groups that I talk to.
Thank you, Rosalind. Have there been any hands that I see? Nick has a hand, so I'll call on you, Nick. Please go ahead. And
I've done it. So
go ahead.
I'd just like to say I'm listening to you all from England, where it's tea time, not lunchtime, and it's been totally interesting to listen to. And I mean, my thing is when to mention it to the doctor, because they always seem to be in a rush, especially at the moment. And you know, I've got to phone him next Tuesday about something I'm doing. So I think kind of get it in there, but he's in a hurry to get off to the next patient. One thing that's been really good is I've been treated by phone, apart from a couple of blood tests that you can't do over the phone. But another bit of treatment I had was by taking a photograph of a funny spot on my hand, and he went to dermatology and came back, and then the spot disappeared. So that was very clever. Anyway, thank you. It's been a lovely, very interesting afternoon.
Yeah, I think your advice though of making an appointment with your main treating person in advance, because if they don't have time, if they can't make time for the conversation about what's down the road, they're gonna have a hell of a time making time if you actually really want it. So it may be try to get their attention, set up, I want to have a conversation with you about this down the road, and I really want to see where you stand on this. So and if they can't make time for that conversation, that's a bit of a problem, right? Because then when you need to have the conversation, it's going to be hard to find the time to have the conversation. And that's even a tougher conversation when you really need it real time. And it takes a little bit of depth exploration to make sure it's the right time. And you want to be sure that person's willing to go into that depth with you if that's possible.
So we are at time. It's 1:30 Eastern. So if we didn't get to your question, our apologies. Please either send it to the chat and we'll respond and follow up, or please send us an email. I'll put our emails in the chat as well. Something I like to tell people regarding their advanced directives is communication is key, and something that Dr. Quill talked about as well, of telling the people who are important to you about what's important to you. It is key. So whether you want VSED or not, really communicating that will go a long way. So round of applause to Tim. Thank you so much. This has been an incredible session. Thank you all for your incredible questions. And thank you to our founder and director, Faith Summerfield, for being present, and to Peggy Batten who will be leading the march in the January lunch hour. So please stay tuned. The recording will be out likely tomorrow. You'll receive an email as well as a follow-up survey to give your feedback on the session. So I'll stick around for any questions. I'll stop the recording now, and we'll look forward to seeing you next time. I hope you have a wonderful holiday season.
And thanks to you, Sarah, for being such a great MC and coordinator.
My pleasure. It's an honor. Thank you, Tim. Bye-bye.